Hi, everyone. Welcome to our podcast, The Animal Heartbeat. I'm here with my friend and vet cardiologist, Kieran. And in this episode today, we'll be talking about heart murmurs in puppies. We'll discuss how to approach a murmur in a puppy. And we'll discuss about differential diagnosis of different types of murmurs and also more complex congenital heart defect, which may be more challenging to diagnose on clinical exam.
Yeah, I think the topic today is going to be super interesting for a lot of people out there, because this is tough, isn't it? When we see heart murmurs in these young dogs that look healthy, it can be really challenging to know what to do for the best. I sort of came into practice thinking, well, I'll just wait and see. I'll reassess this dog at 4 months old. So I used to pull them back and say, come back at 4 months. And then I came to realize that actually that's not the best approach. Because if you have a dog, I don't know how many dogs you've seen with a PDA that are in heart failure by 4 months of age. I certainly have seen them, and it's definitely not in their interest to wait. And maybe, you know, that the first time a vet hears a PDA, they don't auscultate right over the PDA. They don't auscultate high enough or cranial enough. It's really, you know, loudest right behind the triceps muscle, which is even higher than the base, isn't it? It's not like an aortic basilar murmur or a pulmonic basilar murmur. And I think if people just listen to the apex and even just the standard kind of level of the heart base, then you may just hear a systolic component. It may be a grade 3 or even a grade 2. But if you listen high up behind the triceps, you might have a grade 4 or grade 5 continuous murmur, which of course I think most vets would say, oh, that's a problem. We won't wait and see with this one. But the difficulty with the wait and see approach is I would caution against it, because as you say, I think there are problems that could happen there. Now, it's very easy for us to say, okay, let's echo it. You know, I think we would both find it very quick to echo. It's easy to get an answer even from quite a basic echo, but we're very privileged in that scenario. So what would your advice be to vets in primary care practice? You hear this puppy has got a murmur, you think it may be a grade 3, 4 on the left side somewhere, and it's a boxer dog. Is there anything that you would say other than do an echo? Is there any other path that they could take for this case?
Just regarding auscultation, I also wanted to stress that to get experience in trying to detect thrills is really important, because that in some cases that will allow us to detect that high chest PDA murmur that we could have missed if we just auscultate more close to the sternum. And so I generally recommend our residents, before grabbing their stethoscope, to start having that feeling, that memory, that muscle memory of feeling the heart beat. And that gives you a great feeling in terms of how well can you feel the heartbeat. And if there's a murmur where if there's a thrill, then you of course will guide your stethoscope to where you detect the thrill. And sometimes even when there's a clear thrill, with residents, they do not detect the thrill. And I think sometimes the problem is people just leave their fingers on top of the ribs. I think it's really important that the fingers are in the ribs.
It's the intercostal space, isn't it?
In the intercostal space, exactly, to really feel the thrill. And so I think, so one recommendation to me that I always do it myself is, before grabbing my stethoscope, I have a good feel of the heart, to try to feel thrills, to see if I detect something funny. Because then, of course, if there's a thrill, that must be taken very, very seriously.
Absolutely.
Is a clear indication that this dog will have a significant heart defect that needs to be addressed. But especially just to reinforce to stress again what you said, it's a difficult conversation with clients, because we are talking about completely normal puppies. Initially, they are PDAs, pulmonary stenosis,
who are
completely normal.
Exactly, they're running around.
Exactly. And suddenly you ask them to spend 500,000 pounds.
500,000.
I mean, 500.
Whoa, you're expensive, Jose.
That's Cambridge. I mean, something between 500 to 1,000 pounds. Apologies for an assessment by a cardiologist in a puppy that is very normal. So it's challenging. I generally, what I think is important to talk to clients is to explain that there are, at very least, two heart defects that can be easily fixed. And there is now centers all over the UK that provide those minimally invasive procedures. And even if there's not a minimally invasive procedure, for example, for PDIs, there's a solution for those cases. So I think it's important for the client to understand that will have a major impact if a puppy has a fixable a disease that may be corrected.
Right. So the diagnosis is important, isn't it? It's not just, oh, your puppy has something bad and it doesn't really matter what it is. Actually, it really matters what it is, because obviously if we see a PDA, well, we can close that. So our preference is always to go for a minimally invasive approach, transarterial or a transvenous approach to close the PDA, because it's the least impact on the puppy. However, there are things that are more financially viable for people on a budget that are available out there. So there are good options out there, even for PDAs, where the owner may not be insured or may not be able to finance a sort of cardiologist type procedure.
With congenital heart defect, as you were saying, you need a diagnosis, and next you need to stage the disease. Okay, you have the diagnosis, and then you need, of course, to understand how severe the defect is. Does it require correction? Is it indicated for correction? And what the prognosis might be if it doesn't go ahead for a minimally invasive procedure, and so on. So we need to diagnose, and we need to stage the disease, and unfortunately that equals an echocardiogram, a very thorough, careful echocardiogram, because unfortunately thoracic X-rays, ECGs are not very useful, especially when patients are not symptomatic. Can give you some tips, certainly, can with a very good clinical exam, a good X-ray, can give you some tips of what might be going on, but we will need echo to fully diagnose the condition, to understand if there are more than one congenital defect potentially, and then to stage it, to assess the severity. So unfortunately, this means echo. I say unfortunately because if the client cannot afford an echo, it's indeed a difficult situation.
We do echo, right? So for us, it's fortunate. Great, fantastic. We get to do what we love. But you're right. It's a big deal for an owner or the carer of an animal to go through the stress of, I'm worried he's got a heart defect. And of course, a puppy is full of hope and joy. It represents the sort of future of a family or of a relationship with a pet. And then if they're worried about this animal having potentially terminal disease, that's a huge amount of stress, isn't it, to be put under for the owner? And I often find they come into the consult room and they're burdened with stress and worry, and we can echo them and go, hey, look, actually you've got something here which untreated is bad, but we can treat it, and it is in our power to do something positive for your dog. They're a different person. They feel massively empowered and able to kind of deal with this going forward. So I think actually getting an answer, to be honest, even not a good answer, people know at least that there's nothing they can do, maybe if it's a bad disease, or there's something really positive they can do. I've certainly had people who leave the consult room and say, I can't afford a transarterial procedure, but I'm going to go and talk to my vet or a surgeon about ligating a PDA, or they go and crowdfund it. And I've had people go away and crowdfund procedures for these patients in 2-3 days, which is, it's not something I can help them with, and we can't promote that, obviously, because it's a massive conflict of interest trying to raise money for our own fees. But it's great that owners are able to do that, and that's a route by which they can help their animal. You were talking about radiographs and ECGs and how they're generally not useful for these. I would agree. I was trying to think, I wonder if there is a scenario in which we took a radiograph and it was totally normal, and I'd be really happy to say there's nothing significant there. And actually, I think the only scenario would be if we had a right-sided grade 5 murmur. So I'm thinking my main differential for this is either something like bad tricuspid dysplasia, which sometimes you do get these vibrations causing a grade 5 murmur, or more commonly, a small resistive ventricular septal defect. The flow's going from the left to the right through a tiny hole, causing a big high velocity jet and a big murmur on the right. If I've got that patient in front of me and I take a radiograph and there is absolutely no cardiomegaly, I'm really confident in my radiograph. There's no venous distension, there's no arterial distension. The lungs are nicely inflated. You've got a good inspiratory image. The right heart's completely normal on there. And then maybe I repeat that a couple of months later to make sure it's still identical. Maybe I'd be happy to say that is probably a resistive VSD and it's nothing to worry about. That is about the one context that I think I would be comfortable to use radiographs to make that diagnosis. And it does rely upon really confident physical examination and a really nice radiographic set of images, which I'm really confident interpreting. Most people won't feel that degree of confidence, and that is that only one scenario. I think even with a grade 5 left basilar murmur, I'd want to check on an echo that this wasn't something like a resistive outlet VSD, which can localize to the base sometimes, and therefore something we never have to worry about ever again. Or is it something like a pulmonic stenosis that we can do something about? Or is it something like an aortic stenosis where we can do less about, and we may have to think about medical treatment? We may have to think about a shorter lifespan. There's a whole heap of things it could be. So I think an echo really is the only way to go for those murmurs. Is there a murmur you would hear and say, I don't want to echo it because this has got to be a flow murmur? Or something so mild that your referral it's not a waste of time. It gives peace of mind, it gives information, it gives knowledge. But for an owner who might be under some financial stress, is there a circumstance where an auscultation you would say, forget about it?
Tricky question, but I think the example to me would be a boxer with a 2 out of 6 basilar murmur, where right. I only detect a murmur really at the base, under the armpit, high in the chest. I can only hear the murmur. That very careful auscultation, and the only place I can find the murmur in a boxer is high in the chest. This is most likely to be associated either with a flow murmur or a mild form of subaortic stenosis. And mild form of subaortic stenosis are associated with a very good long-term prognosis. In fact, we face that sometimes in referral practice in the place where I've worked. Like a boxer that another service finds a murmur and they want a pre-GA assessment. And it's not uncommon. Then we end up discussing in clients that may not need a boxer that needs surgery and they don't have the funds and so on to say, well, in terms of probabilities, again, if we want, this is a boxer. The murmur is very mild at the left base, so soft. So I think that would be the scenario in comparison with your example of a case that I'm a bit more relaxed. Again, if they want to know for sure you need an echo, I think that will be the scenario. Before, I wanted also to hear what, if you have a different opinion about that, but just to stress what you just said, as a rule, murmur grade is associated with disease severity, and that's true for myxomatous mitral valve disease, and is true for subaortic stenosis, pulmonary stenosis, and the exception is the VSD that you just mentioned. So just for any vet out there that has not realized it, I'm sure everyone knows this, but now I'm sure, but just the VSD is an exception where a very loud murmur is associated with a resistive, restrictive defect, and so associated with very good outcomes. And so is the exception. Otherwise, a loud murmur, unfortunately, most of the times would mean an advanced or significant, clinically significant cardiac defect.
So if you have that scenario where you have a puppy who's got a very quiet murmur, what clues on physical examination or history might make you think, actually, this is more significant? This is more likely to be either a complex congenital heart disease or a large VSD with a significant overload or whatever. What are your other cues that make you more concerned?
So in case like that, I would already expect some clinical signs. So if we have a soft murmur that is associated with a large VSD that might be now bidirectional, or a more complex congenital defect, I would expect clinical signs. I would expect that the puppy is not exercising as a normal puppy should be. They may not be putting the weight as they should. Talking to the client, sometimes they will describe that the puppy stops playing suddenly, and then carefully asking, they may have noticed that the mucous membranes may get very pale or slightly cyanotic. So I think in case that a soft murmur is associated with a more complex congenital heart defect, I think these puppies have some symptoms.
One of the big challenges, I completely agree with you, and I actually think muscle condition or body condition is really important, because often we get those puppies, and again at vet school I was taught maybe these animals are stunted. And when I graduated, I didn't know what a normal Norwegian Keeshond looked like. To be honest, I don't know. I think I've only ever seen one Basenji, for example. And, there's plenty of breeds out there. I don't know what their puppies are supposed to look like. And obviously now we have, I don't know, the cockapoo. Goodness me, cockapoos come in all shapes and sizes. So I don't know how stunted one is compared to the next. I think body condition is important because often they're quite skinny. You really feel their ribs and you think, oh, this puppy, it's got that normal puppy pot belly, but the ribs are really prominent, or the spine is prominent. And I think those guys, often when you find that, I think, oh yeah, maybe it is a little small for a Labrador at 10 weeks old. So I think often with bad congenital disease, these complex diseases, VSDs, tetralogy of Fallot, truncus arteriosus, these very complicated things, AV septal defects, they're not so common. But when they present, even with a quiet murmur or no murmur at all, there are other cues that warn you about something going on. One of the problems actually with the sort of idea of interrogating the history about exercise and behavior and things is number one, they might be a first-time dog owners. They don't have a frame of reference. They, oh, well, the last Labrador we had did this. If it's their first dog, they say, oh, he sleeps a lot.
Yeah.
That's what puppies do. Actually, I mean, obviously they're on or off, and some owners don't understand that. I think the other thing is brachycephalic dogs are really hard to assess. Their breathing's hard to assess, sure, but they may stop during exercise because they've got upper respiratory tract obstruction. They may make respiratory noise. They may even experience syncope episodes or sort of pre-syncope because of the nature of their brachycephalic conformations. So those guys are really hard. And of course, the breeds that we tend to see, not tend to, but that we often see complex congenital disease in are brachycephalics. So I think they're really challenging. And breed's definitely important for me in assessing these. Circling back to what you said about boxer dogs, I totally agree with that. That was exactly my scenario where I would have gone, yeah, it's probably nothing to worry about. The other one is that sometimes I see small dogs, often these small white dogs, so 1 year old, 2 years old, actually with quite a musical murmur. And I don't know if you can identify with this, but the murmur sounds like a whoop, whoop. They're very hard to grade, because they sort of resonate. So they sound louder than the heart sounds. But when they have that resonant frequency, that musical quality, I find it hard to grade them. So I would call them musical, loud. I don't know if them being louder than the heart sounds mean there's worse disease. I don't think that's always true. And many of those 1 year old, 2 year old little white dogs, they will have flow murmurs that are quite musical, sort of aortic flow murmurs. And often you echo them and you can't see anything at all. And you measure their aortic flow velocities and they're just sort of, I don't know, 1.8, 1.9 meters per second, where you're just thinking, okay, well, it's not stenotic. There's no 2D lesions for stenosis. There's nothing here that says there's a congenital defect, but the flow's a little bit fast. And maybe that's enough to cause that vibration. And sometimes on the continuous wave trace of the outflow in those dogs, you'll see a little musical frequency, like vocalizing. Have you seen that, or am I just making this up? Am I talking rubbish?
No, I agree. I did. I spent a lot of time to look for chordae vibration, mitral valve vibration.
Okay.
I spent a lot of time, and I probably most of the times failed to find anything. Generally, the case we hear with musical seagull. I like the seagull call.
Seagull call. Yeah, do an impression for us of the seagull murmur.
This is not a seagull. Well, it's a Portuguese seagull.
Okay.
This is
it's a Portuguese seagull.
It's a Portuguese seagull with cough. But yeah, I think this honking sound.
Yeah.
And so we generally see it when we see them are like early mitral valve disease associated generally with vibration of the mitral valve leaflets, very early mitral valve insufficiency, mitral valve prolapse, and so on. So then when I hear that in young puppies, I also try for a long time to look on echo if I see anything like that, vibration of a chordae, mitral valve, aortic valve vibrations, which generally I fail. And but it's also important for vets to detect those musical sounds, because then if you detect them, it is another scenario which you could say, even though it sounds very, very loud, generally they're associated with a rather benign process. You need an echo, of course. but generally associated with a rather benign process.
We've mentioned breed here. Are there any other typical sort of breed predilections that you see for flow murmurs initially? So you mentioned boxer dogs, and I completely agree with that. The little white dogs, I don't know how else to describe them. They're often crossbred, some sort of terrier cross, hairier than a Jack Russell. I don't know. These sort of, juvenile dogs, not puppies really. I think also for me, English Bull Terriers, they often have, like the boxer dog, quite a small aorta, I think, relative to ventricular size, which has two implications for us as cardiologists. One is they often have sort of grade 2, 3 murmurs at the left base, which could just be flow and not actually really a congenital disease. The second implication is that if we are echoing them and measuring their left atrial size, and our default is to measure LAAO, so left atrial diameter to aortic root ratio, they're going to measure large. And this has generated a whole heap of discussion and things amongst cardiologists. But, boxer dogs have a bigger LAAO because their aorta is small as a breed. It's nothing to do with their atrium, I don't think. Are there any other breeds that jump out for you?
I agree. Brachycephalic dogs, generally brachycephalic dogs are the ones I have that problem. I wanted also to say, as you mentioned before, those brachycephalic puppies, especially when they have severe BOAs, they are incredibly challenging to assess and also to auscultate their heart. And so those are the guys that sometimes murmurs are missed, that you have a lot of hyperrespiratory noises referred in the chest. So those are cases very barrel shaped. Those are the cases that sometimes I think we end up detecting congenital heart defects when they are 2, 3, 4, 5.
Right. Or when they present with right-sided heart failure or something, or AF or something. Yeah, I agree.
A murmur was missed, but those are challenging dogs to do good clinical examinations. The other flow murmurs I generally detect in our clinic are like deep chest dogs, like greyhounds, whippets.
It's the sight hounds for me. Yeah,
the sight hounds. Exactly.
Yeah, I think what's quite important to say about these breeds that we're talking about now is often these guys can be 2, 3, 4, 5 years old and they'll still have a murmur. It's not about them being a puppy, it's about their conformation. But of course, because it's there from birth, and actually in juvenile dogs, owing to the maturation of bone marrow and changes to blood viscosity and things, those murmurs may be transiently a bit louder when they're the sort of age where they're being vaccinated and neutered and things. So this is often when they're picked up. And the first thought could be, I'm really worried about congenital heart disease. It's not wrong to worry about that. Of course, we're cardiologists. We see bad congenital disease. But if we can identify that these murmurs are quiet, they're focal, maybe they change with heart rate. That's another factor that might hint at a flow murmur, is their dynamic. So they increase in intensity at higher heart rates and decrease in intensity at lower heart rates. They don't radiate widely across the chest, and sometimes maybe they're absent, actually, that they can be intermittent. These are all findings that would make me say, okay, this dog's more likely to have a flow murmur or something so mild that it's not relevant to the dog. Now, the proviso there is that, there's no clinical signs. They're well grown. And if they're not a little puppy, it's easier to assess their body condition, their muscle condition, their exercise tolerance, because they've been tested. They've been out for a run with the owner, maybe. Oh, yeah, I run 10K. He must do 25, across the sand dunes in South Wales. Well, that dog probably doesn't have significant heart disease. So I think contextualizing these murmurs is important. If you have the same murmur, a little low grade, grade 2, left basilar murmur in a puppy that's poor body condition, is not exercising well, maybe the respiratory rate's a little higher than you'd like it to be, those are big red flags for me. And that's a murmur that should be investigated compared to the murmur that you might just ignore in a 2-year-old robust boxer dog. So I think breed does come into it. The next thing we should think about, we talked about the sort of context and the body condition and clinical signs of these murmurs. What about a breeder who comes to you, or an owner who says, I just love her so much, I really want to have a litter of puppies, but this young boxer dog has got a grade 2, maybe a 3 at higher heart rates, left basilar murmur. We've said that maybe it's not significant for the dog. Maybe it's a mild subaortic stenosis. The dog's asymptomatic and grown well. The scenario is quite different, isn't it, when you're planning to breed?
Exactly. It's a completely different league. Similar to HCM screening, we are then looking for perfect dogs or cats. And so we need to be sure that they do not have any underlying structural heart disease, even if very mild. Because what the breeders would potentially, breeders know a lot about genetics nowadays, and they're very well informed and try to do a very thorough work. But maybe a more cheeky breeder could tell, oh, this is just mild, and is a great dog. So I would anyway use this dog in my lines. The problem, of course, if a mildly affected dog with another mildly affected dog may cause very, very sick puppies. And
there's good data supporting that, isn't there? From the 70s, from the 80s, Lee Pyle's work on aortic stenosis and all of that stuff is critical to our understanding there.
Exactly. And so in those cases, in fact, the breed screening for boxers requires that we first auscultate a dog and detect them and look for a murmur. If there is no murmur, great, they are clear. If there's a murmur, depending on the grade, there is still very soft murmurs. You can still auscultate them later on. But I would recommend an echo for a breeder that wants to do a very thorough work, that wants to be sure that their lines are clean. In that case, we definitely need an echo. So with breeders, is indeed a different league and a different scenario, because we want to know if this dog has a perfect heart, and the cost is huge. If then they start having litters and puppies, or sell those puppies and so on, the cost is huge.
And I think the impact of one dog, especially a male dog, is massive, isn't it, in the breeding population? So there's a really good example, not from congenital heart disease, but from arrhythmic cardiomyopathy in boxer dogs, formerly boxer cardiomyopathy, or ARVC, when actually in the UK at least, you can trace back many of the affected dogs through their pedigree lines to a dog called Abel Seaman, which was imported years ago. And actually this dog, ironically named, has bred widely because he was a grand champion and passed on the genetics for this awful disease to lots and lots of dogs. So if we have a dog with a very mild aortic stenosis but has potential to throw the genes out there and combine them with other genes in the female dogs to generate severe aortic stenosis, that could actually be a huge welfare impact on the population. And of course, if it is a good dog, we don't want to exclude them just on the basis of a murmur, because it is a boxer dog. So I think an echo in those cases not only helps us to think about excluding the dog if there is bad disease, well, any disease, but also it helps us to include the dog if there's no disease, because we don't want to narrow the gene pool. There's huge examples throughout the history of breed screening in veterinary medicine of people rashly excluding animals from a population, and then later on seeing the impacts negatively on the genetics of that population. The one that springs to mind for me is ragdoll cats with HCM, where the genetic test came out in 2007, was commercially available. Anything that had a positive heterozygous homozygous was excluded from the population, which narrowed the gene pool. And the breeders all decided in the UK, well, hey, let's back cross these with Persian cats, because the ragdoll line has some Persian in anyway. Let's expand that. And now the ragdolls since then have a lot more polycystic kidney disease, which is traditionally a Persian disease. It's tough. And we don't know what we're doing with this. So I think for me, it's paramount not to excessively narrow the gene pool in a breed, but we've got to take these mild murmurs seriously, I think.
I agree, totally agree. We have been talking, and the topic is heart murmurs in puppies. But let's say, can you comment on congenital heart, and the majority of congenital heart disease we see will cause a heart murmur? But can you comment on congenital heart disease that may not cause a heart murmur? And as this might be important for vets to be aware of.
Yeah, and that's hard, isn't it? Because it's hard to say there's no congenital disease here based on physical exam. The classic diseases we see, certainly in Europe, the big three diseases in dogs are pulmonic stenosis, number one, aortic stenosis, number two, PDA, number three. They're very close together, those second two. And then I think probably VSDs after that. In cats, it's all VSDs pretty much, and VSDs and horrible complex disease is what I see in cats. Yesterday we did a balloon valvuloplasty in a cat with pulmonic stenosis, but that's very uncommon. For me in cats, it's all VSDs. So dogs have a much greater range of congenital heart diseases, and I think anything where there's a large VSD is a very serious disease. but often doesn't have a murmur. Tetralogy of Fallot, which of course is a VSD, malpositioned aorta, right ventricular changes, and a pulmonic hypoplasia, those cases will have a murmur from the pulmonary stenosis induced by the hypoplastic pulmonary artery. But things like a truncus arteriosus, say, where we have a large VSD, a single vessel coming off the common ventricle, if you like, which then goes to the pulmonary artery separate to the aortic arch, those cases won't have a murmur. But they'll be cyanotic looking, they'll be weak, they'll be undergrown. There are huge problems with those dogs, and they should be reasonably obvious on physical exam. I've seen a couple of cases of truncus arteriosus in cats in middle age. So cats are different. They don't show the same signs that dogs do. We know that. I think the other thing is atrioventricular septal defects, formerly known as endocardial cushion defects. These are basically a low ASD, so primum type ASD, an inlet VSD, and AV valve malformations. Now, they may have significant valve regurgitation, which causes a murmur, or they may not. Depending on the sort of where they are on the spectrum of complete atrioventricular septal defects all the way through to sort of partials, the murmur varies according to the specific hemodynamics in that patient. I've certainly seen them with no murmur at all, and they've got a shocking heart that just fills the chest and goes wall to wall in the thorax, and their prognosis can be pretty terrible unless open heart surgery is an option. I'm trying to think of course, right to left PDA is a classic. So these are often dogs where they have a large PDA more often than not, and the typical time for these right to left PDA dogs to present is actually around age 1 or 2. And they often don't present to cardiology. They either present to neurology for hind limb weakness at exercise or hind limb collapse at exercise, and people think they're neurological, or they present to internal medicine for polycythemia, I should say. Erythrocytosis is the correct term, because it's a non-neoplastic proliferation of red blood cells. And actually, that is appropriate, that polycythemia, because these dogs are right to left shunting through their PDA. They've got severe pulmonary hypertension, which is the same or higher pressure than the aorta. And during exercise, they get hypoxic hind limbs. Their kidneys receive a huge amount of deoxygenated blood. So the erythropoietin kicks in and pushes their PCV up. I have seen a couple of them present with neurological signs because of high PCV. But that seems to be the less common way for them to present. Normally they come in through neuro or medicine. And they're very challenging cases, because at that age, it's very unlikely we're going to get them to normalize their shunt, if you like, to be able to control their pulmonary hypertension using something like sildenafil. And often those guys are about long-term management of erythrocytosis and the degree of shunting. We've had some of those dogs live to 13 years old. So it's not always a death sentence, but the key thing is identifying it and not putting them through MRI, and actually, not suppressing their erythroid line with drugs, but actually trying to manage their shunt as best we can. Yeah. How often do you see those right to left PDAs in these more complex diseases, Jose? I think I probably see a few a year, maybe 3-4 a year of the right to left PDAs. The complex diseases, it's hard to put a figure on. We see them every month, I think.
More in cats, as you were saying.
More in cats.
Yeah, again, it's a puppy podcast, but what you were saying is important. Cats may present with congenital advanced complex congenital heart disease at middle age. And so it's important maybe to add up to our last episode that some murmurs in cats may also be associated with congenital heart disease.
Sure.
But as you were saying, the big three, it's important to recognize the big three. In terms of congenital heart defects, those are by far the most common defects that everyone will see in primary care settings and referral practice. And then also rare stuff like triatriatum dexters.
Oh, sure. I completely forgot about those guys.
Yeah. And then, of course, ASDs will not cause murmurs.
Right.
You mentioned the AVSDs, and just if we would only have, of course, a type of primum or secundum ASDs, or sinus venosus, any ASD would generally not be associated with a heart murmur, but those are rare. Those are.
I don't think we see those isolated ASDs really in this country, certainly in practice. I know Sonia Gordon and the team at Texas A&M have published on closing these ASDs. A lot of standard poodles in the ASD group there. So they've got great experience of that. I've closed one in my career so far. I think we don't see many isolated ASDs. If I get a referral from a primary care vet who's maybe put the probe on in sort of a triage echo and gone, I think there's an ASD, I always think, okay, statistically, it's much more likely that we would see an atrioventricular septal defect or something more complex than just a simple ASD?
Echo is challenging, and diagnosing congenital heart defects is very, very challenging on echo, because of course we are dealing with small puppies that will be moving all the time, with sometimes very abnormal hearts, and requires a very thorough assessment. And then assessing the intra-atrial septum, as you were saying, is very challenging. Sometimes the inflow from the caud or craniovena cava may mimic a left-to-right ASD, so we need to be very careful. As you were saying, we may have patent foramen ovalis associated with pulmonary stenosis or other right-sided diseases.
I know there are going to be vets out there listening to this who are thinking, well, why not use some cardiac biomarkers? If we've got a heart murmur in a puppy that presents and we're not quite sure, is it a 2, is it a 3? The owner will spend the money for referral, but they're not quite, if they need to, that they will spend the money, but they're saying, well, do I need to? I read on the internet about a cardiac blood test. Do you ever use cardiac biomarkers in these congenital diseases? Do you think they're useful?
Honestly, I generally don't. And I don't, to be honest, I don't really have much experience with it. We randomly receive cases with, again, is a referral bias, where there was a murmur and a very loud BNP, and we see those cases. And so it makes sense if there's marked cardiac remodeling, increased wall stress, increased wall strain, that BNP will be increased.
Do you know what? That makes sense. I just don't think I've seen that. I think I have seen high, sure. Yeah. But I saw a Labrador, I remember, with shocking tricuspid dysplasia, huge right heart. I mean, it was, massive right-sided cardiomegaly. Dog was in right-sided heart failure. Its NT-proBNP was 400 or something. I mean, just not high and not really flagging for me. We published a study a couple of years back on using atenolol preoperatively in dogs with pulmonic stenosis. That's not the point of what I'm saying. The point is we ran cardiac biomarkers. We ran troponin in those dogs, and we ran baseline, we ran it after treatment, and then we ran it after ballooning, and none of them had a high troponin at any point. So these were dogs with bad enough congenital heart disease to undergo minimally invasive surgery. Some of them were in heart failure, and their troponins were basically normal. So I think that maybe some cases will push the cardiac biomarkers high, but if I see a high troponin in a young dog with clinical signs or an arrhythmia or a murmur, I'm thinking about myocarditis actually, much more likely than it being related to congenital heart disease. So I'm not sure they're very useful in congenital heart disease, but we're in an evidence vacuum really here, aren't we? That there's no paper out there on this, but my feeling is they're not very useful. The second question that I was thinking about from the point of view of primary care practice was about the triage echo. And I mentioned that, we see cases sent by primary care practitioners locally where they've heard a murmur, they've put the probe on, and they've gone, oh, looks like a massive right heart, I'll refer it. Do you think that's something that could be in the toolkit for practitioners to use if they've got a bit of comfort doing, say, lung ultrasound or POCUS in a dyspneic patient? Do you think they could extend those skills to young dogs with murmurs, or do you think there are any pitfalls there that would make it something to avoid?
More and more vets have experience at doing point of care ultrasounds. So I think it could be worth it for them to do it. But I'm worried that these are very challenging to scan these puppies. And then of course, if you see a gigantic right ventricle, that could be associated tricuspid dysplasia, or very thick right ventricle for pulmonary stenosis and so on, or a big left ventricle, great. But still, you will need a thorough echo then to stage the disease and to understand, is it indicated to go ahead with a minimally invasive procedure? And so if the owner has I don't know, just thinking out loud, if the owner could not afford referral or was not sure about referral, and then a POCUS would show LVH, RVH, a big left ventricle, then maybe that could help the vet discussing with the client, and there is structural heart disease, and we need to refer it for a full echo. But again, I think it works better. A vet found something in a POCUS. Anyone finds something in a POCUS that could help. Okay, this case needs to be referred. But then if you find nothing in a POCUS, I would still be worried that there might be something significant that was just not possible to see in a very brief standing echo.
I think if we think of it as like a a diagnostic test, like a blood test.
Yeah.
People talk about
Yeah.
sensitivity, specificity.
Precisely.
So I guess it would be quite specific in
Yeah.
a positive, a huge
Yeah.
right heart, a massive left atrium, or I don't know, pleural fluid, pericardial fluid might rule it in. That would be specific, but it wouldn't be very sensitive. So a negative wouldn't rule it out. I think that's how I feel about it. I do sometimes see false positives, if you like, where a vet's put the probe on and gone, oh, the right heart looks massive. And actually, I would say I echo and it looks normal, and probably they were just a rib space too cranial compared to where our standard views would be, or their angulation was just a little bit off. So that, you know, that there's so much operator dependency in echo, but I think there's a place for it, and I think it can maybe it can help persuade those owners who are sort of sitting on the fence.
Exactly.
I'm not sure, he looks fine to me. If the vet puts the probe on and says, oh, his right heart is bigger than his left, okay, the owner comes to see a cardiologist. So maybe that's the place in which they could reach for that as a sort of screening test.
Great.
I think that's about all we have time for on this episode of the Animal Heartbeat. Jose, thank you very much. It's been emotional.
Thank you, and see you all in our next episodes.
Yeah, I think you know, we're looking forward to some guests down the line, and if anybody out there wants to follow us on socials, we're on Twitter and Instagram at @heartbeat_pod, and we're going to tweet some images of the things we're talking about in these podcasts when the podcasts are released, so you're going to be able to see the examples of things we're talking about, and also that's your opportunity to get involved with us and to put any questions to our forthcoming guests. We will announce them on the socials as we go. So thank you very much for listening, and please remember to subscribe in Apple Podcasts or wherever you get your podcasts from. Thanks very much.
Bye now.